So I need your attention here, okay? We're going to talk about sustainable development.
I would say the vision of the World Youth Alliance is of personal excellence. You see all of these young people from all around the world. They care about others, they care about the world.
We all have the same mission because we all want to change the world. We all want to change our societies.
Everyone's talking about human rights, but no one knows why they're protecting them.
They're looking for answers. Who am I? Do I actually matter?
How can I really implement human dignity in my day-to-day life?
Just that idea that if you believe in something enough and you work hard enough, you can really change the world with something as simple as the idea of the dignity of the human person.
If you can teach people lessons of human dignity, there will be a lot less massacres or genocide. Which is why principles that YA stands for, which is equality and dignity for every human being, is very important. Because unless you know why you're fighting for something, I don't think that goal can be achieved in the short term or even in the long term.
YA is really making me see the beauty in a person despite everything else and making it something more than just ideology or a theory, putting it into practice and really kind of starting a revolution.
I think there is an urgency in terms of our work. I don't see anyone else doing the work the World Youth Alliance is doing. Freedom is this huge burden of responsibility, but also power in that sense that through ideas you're shaping your surroundings and trying to sculpt them towards something better.
Human dignity is how he is to improve himself for what is true and what is beautiful.
Definitely an urgent time to point out those inconsistencies in our different ideologies and show that we need to be consistently affirming the value of human life at all levels, otherwise we all become vulnerable.
Organizations like World Youth Alliance have to exist because there's a constant need for someone to stand up for the little guy, the person that has no voice, and that's what World Youth Alliance does.
Everyone. My name is Eva Reimann and I am the chapter coordinator for World Youth Alliance Poland. I'd like to welcome all of you to our Human Rights webinar today. Human Rights webinars are the summer project of YA Poland, for which we invite international experts to discuss some of the most important human rights issues, and then we try to reflect together upon them. We are hosting 5 meetings in 5 weeks, and it is the 4th one already today. Having said that, I'd like to officially welcome you to our live broadcast. Thank you so much for being with us. In a moment, our speaker Nadja Wolfe will join us live from New York, and we will listen to her presentation. After the session, we are going to have Q&A session, so please stay with us. But before we go to the program, we want to know more about you. We hope you could join us in the comment section and let us know where you are from. Kindly send your name and the country you are representing. Also, if you want to get more involved in YA, if you want to become a member, you can visit waya.net/get involved, sign the charter and sign up. I see some comments coming already. So hello Kacper. I guess from Poland. Hello Dora. It's good to see you. It's good to have you with us. We hope that there will be more of you coming, that we'll see more comments coming. We would really love to hear from all of you, so we encourage you to let us know that you are here. During the session, if you have questions to our speaker, feel free to send them through the comment section, and we'll try to answer them at the end. Moving to the program, for today's session, we will be discussing assisted suicide and euthanasia. Let's all welcome Nadja Wolfe, our speaker. Nadja, hello Nadja. Nadja has served as WIA's Director of Advocacy since 2015, overseeing the organization's advocacy efforts and representing WIA at the United Nations. She is a graduate of Washington and Lee University and William and Mary Law School. Thank you, Nadja, for being with us. And now the floor is yours.
Thank you so much, Eva. I'm really glad to be here with you. This is a topic that means a lot to me. It's one that we worked really hard on with one of your previous speakers, Hervé, to put together a white paper on it. And we just also added to that with an appendix that we finalized this summer, showing all of the kind of going into the laws in different countries and states around the world. And so I'm very glad to be talking on this and hope to get all of your questions. I might have anticipated some of them. I might have left something out. So, I'm happy to answer whatever you've got. And also to get started with my PowerPoint here. So I've tried not to put too much on the slide so that there's some value to me being here, not just slide sending, but just to kind of go through and speak with you about some of these things. So this is what I'm planning to cover. We're going to go through just a little bit to make sure that we're all on the same page. Some of these terms are, they do overlap or there's lack of clarity about them. So I'm going to explain how I'm planning to use them. We're going to talk about kind of the right to die, dignity, and the law itself and what's coming up there. Some of the arguments that are most common for this, these really fall into kind of two broad categories. And also talking about how to answer some of those arguments. So I'm never going to give you only the argument, but I do want to kind of explain it. And I think that their arguments do have some appeal. So it's really important to understand them to be able to answer them. And then also talk about some of the concerns that we have related to vulnerable groups, people with disabilities, and some other issues. And then also, of course, how do we actually ensure that we do respect dignity and end-of-life care? Because I don't think that these things are coming out of nowhere. There are valid concerns behind why some groups might be advocating this, advocating these practices. So definitions, clarifications, make sure we're all on the same page. This is the way that I'm going to use these terms. First, with euthanasia. That's intentional killing by act or omission of a dependent human being for his or her alleged benefit. Certainly, this term has a lot of, it's a pretty loaded term. I understand it. In Poland, you're very familiar with things that went down during the Second World War. This was certainly a practice that a lot of people are very uncomfortable with the term itself, or they are very careful to distinguish that they're not talking about just killing people because they think that a disabled life is not worth living or things like that, but because somebody needs help to end their life. So we're not, the way that it's usually presented is as voluntary. So there's some sort of request by someone, but they're not carrying out the act themselves. And then when it comes to assisted suicide, the difference is really that the physician is taking direct action to assist them, but they're not actually performing, like administering whatever is going to end the person's life. So that's the definitions that I'm going to use. I probably will say assisted suicide most often. Some places do allow both, but you can take it to generally the arguments are the same in both cases. It's just the difference really comes down to who's doing what in it. The other thing that I want to distinguish is that we have a couple of key elements. First would be actions, right? So are we, what's the action that's being taken? Is a doctor, for example, administering or just providing a lethal dose of some sort of medication? So we actually give someone or administer to someone something that will end their lives. Or is it also possibly an omission? And this is a recent case. It's not in the white paper, which I do encourage you to read. We have a recent case in the U.S. in light of COVID-19, where we have a man named Michael Hickson. Texas, the state of Texas has like a medical futility law where doctors are allowed to discontinue or not offer treatment within a certain period of time if they think that it won't be a benefit to the patient. In Michael Hickson's case, he basically did not receive treatment for COVID because he was disabled. And the doctor pretty much told his wife that, and she recorded it, that because, you know, his quality of life was pretty bad because he was disabled, it wasn't really worth it to save him. So that's probably not direct euthanasia, but that's the sort of thing that we're looking at when it comes to omission. And then of course, we've also have intention, right? So what are we doing and why are we doing it? For this, it comes to, I've got a couple examples. One would be the Vincent Lambert case, which you may be familiar with. That is a French case from last summer. It is now kind of working its way through some of the disability. The Committee on the Rights of Persons with Disabilities tried to intervene and ask France to reconsider, or at least give them time to look at the issue. And the French government said, no, this is what we allow. But in Vincent Lambert's case, he also had a disability. He had, I think, suffered in a car accident. And so he was not as conscious, but he was alive. He wasn't in danger of dying. And under a French law, his wife was allowed to basically remove water and nutrition from him. Now, so we're not talking about something where his lungs would not work on their own, but we're talking about just basically food and water. And without that, he basically starved and dehydrated to death. Another thing is pain relief use. So when somebody's, you know, at the end of their life and experiencing great pain, they might need extreme pain relief or things that could actually have an effect on their ability, for example, to breathe. So some high-level painkillers might actually compromise breathing to a certain amount. But the question is, are we trying to actually stop them breathing, or are we trying to relieve their pain and we accept that it might actually have an effect on their health to the point that they might die a little bit sooner? We don't know. That's not the intention. But you see how these things overlap, and how there's actually, you know, you can have the same action, but it's not necessarily it's not necessarily done with the same intention, and that can make a big difference. You know, when it comes to food and water, there might be a point where somebody really can't process food and water anymore, and all you're doing is adding to their suffering. They're very close to death or things like that. So it's really a very fact-specific analysis. We're not looking at any case where we can say, here's the hard and fast rule: never remove nutrition or water, never give a high dose of pain relief. It really comes down to that kind of holistic approach and say, okay, why are we doing this? What are we doing there? As opposed to, of course, if you specifically give someone something to end their lives, that's much clearer. But it can be much more in a gray zone otherwise. And also, just to make sure we all kind of are familiar with this is where assisted suicide and or euthanasia are legal today. So I've got them both kind of put out there. Switzerland has a little asterisk because Switzerland, it doesn't have to be a doctor. You can see that they're pretty early. The U.S. states have legalized from 1997 to just last year. Italy and Germany, the most recent, and they're assisted suicide only. So in that case, they can provide the means to someone to end their lives, but they're not directly administering anything that would end their lives. And in Switzerland is an interesting case because Switzerland actually is largely run by kind of private charities. I watch some British comedy, and somehow there always come out jokes about like Dignitas, which is one of those organizations. And then, of course, you've got Belgium, Netherlands, Luxembourg, Colombia, which is really an outlier when you look at all of the other countries that allow it. That was a constitutional court decision there. Canada just recently, and Australia, not the whole of Australia, just the state of Victoria, passed a law in 2017, and it came about in 2019. Of these, the state of Victoria has the kind of most stringent requirements. Although, in my opinion, most of these things, because they're all reviewed after the fact, there's very few checks before to see, is this actually a case of that? It's very elastic, and really nobody's been punished for doing anything wrong under these laws. Most of the time they're considered justified. Netherlands, Belgium, and Colombia have 2 little stars next to them because in those countries, actually, you can be a minor, you can be a child, and have assisted suicide. Netherlands has basically tolerates what's called the Groningen Protocol, where newborns who have severe disabilities or serious medical conditions can be euthanized at the request of their parents. They also allow children who are over 16 years old to request assisted suicide or euthanasia, and younger than that, the parents have to consent, but they can. I want to say 12 years old, but it might be there might be a different age limit there that I can't recall right now. Belgium also allows child-assisted suicide or euthanasia. They actually don't have an age limit. What they have is a requirement for some sort of psychiatric or developmental assessment. And Colombia, so Colombia says 97, 2015. 97 was when the decision came out, and the government basically didn't create any rules for it. So it was this big kind of open situation where you probably couldn't prosecute somebody for doing it, but there were no real guidelines. In 2015, they put out guidelines, and then within another couple of years, they came out with guidelines for child euthanasia based on another court case. And it actually contemplates children as young as 6. They would have to be assessed between the ages of 6 and 12, and parents are supposed to be involved. But it's really stunning how kind of quickly it goes from, okay, so this is adults at the end of their lives. Maybe there's some level of freedom there to really complex situations that are happening. So what is this kind of idea? And a lot of it is put as a right to die. You might also hear things like death with dignity, which is a pretty troubling term, but also one that we see a lot in the WIA context. And so that's really one that we like to address, and we want to make sure that we're talking about here. So right to die, I just want to kind of go through the main argument. So basically what we see is there's a right to die as part of either or both the right to life or the right to private and family life, which is something that's very European. You might know that from your European Convention on Human Rights. And so we have to kind of think about that. Is this accurate, right? Does the right to life include the right to choose how you end your life? And the answer is, this is not accurate. And how do we know? Well, we have to think about how rights are created. So if you've done your certified training program, or if you have studied international law at all, you know that we establish kind of human rights through treaty and custom. Treaties, we actually go through and countries negotiate, and they agree that this is a binding set of obligations that they have. And custom are things that arise from the practice of states over and why they do it. So we can see, even though that list is getting longer of where assisted suicide or euthanasia is allowed, it still is a relatively small list. There's, 190 plus countries in the world. So there's no custom there. And what we have then to look at is the right to life. And we tend to look at, how it has that been interpreted, was what was understood at the time when that was codified into international treaties, and nobody believes that it included the right to end one's life. And the European Court of Human Rights has also basically said, maybe there is something here about not criminalizing suicide, but states have some really valid interests in protecting the vulnerable, ensuring the integrity of the medical profession, protecting human life. And so those have been recognized in a number of judicial decisions. That said, there are some concerning trends, because we don't just have judicial decisions that are positive on that, although we do have some, but we have seen more and more national court decisions that are problematic or challenging there. So Colombia, Canada, Germany, and Italy are all court cases where courts found within their own national laws that this was something that should be allowed. And we also have at the UN level, there is the Committee on Civil and Political Rights, or the Human Rights Committee. It's the Civil and Political Rights Treaty that they're monitoring. And they put out a brief on the right to life, and they suggested that it could include this kind of right to death. They toned it down a lot because they got a lot of objections, but there was a level of acceptance of that I found troubling, and that we certainly opposed. We submitted arguments on that. So the basic argument goes, look, right to life, that it's not just about being alive, it's about living the life that you choose, about that kind of basic autonomy and freedom, and that should include how your life ends. And if someone wants to avoid pain or suffering, or they don't want to be dependent, all those kind of things which are undignified at the end of their life, they should have the right to do so. And so therefore, we should allow death with dignity via assisted suicide or euthanasia. And that's kind of your basic argument. So how do we answer that, right? That dignity word comes out a lot, and it seems to be treated like it means the same as the ability to choose, right? But we're WIA. We know that's not just what it is. So what is human dignity, right? Do you lose your dignity in certain circumstances, right? So for us as WIA, human dignity is the innate value of every human being. It's intrinsic, it's inviolable, it's inherent. You have it just because you're human. You don't have more of it because you're really smart. I'm sorry, I'm sure you're all brilliant. You don't have more dignity than someone who is less smart than you. You don't have it because you're very strong. You don't have it because you're the best violinist. You don't have more of it or less of it. You have the same amount as everyone else because it is our fundamental equality of being human. That is why we have it. We are all human, even if our gifts, our talents, our abilities are different. Okay, we don't have more or less. You don't have more because you have more money, even though it might feel like that sometimes. That's what it is. So we have to think about it in that way. And then we have to think about who has it and when. As I said, it's everyone. Do you have it throughout your whole life? Yes, or it doesn't mean anything, right? Well, you pick up some dignity when you're about 5 years old, and when you kind of lose your senses when you're old, you don't have it anymore. That's not something that is intrinsic, inherent, inviolable based on you being human. Those are other characteristics, okay? And if it's about being reasonable, then, well, we're all unreasonable sometimes anyway. So what are the implications, right? If we make dignity kind of dependent on, I don't depend on anyone, or I can care for myself, or I'm not experiencing pain and I can do what I like, well, dignity is really the foundation for why we think anyone deserves human rights to begin with, or has those human rights to begin with. We have human rights because we have this innate value. We don't, our dignity has to be that foundation, or we can just kind of take away rights, and there's no grounds to oppose it. So if we're saying, we lose our dignity if we have a difficult, disease or experience at the end of life, then that has a lot wider implications that most assisted suicide advocates don't like to engage with. And so it's really important that we take that and oppose that, especially in that term. So I don't know how it works in Polish, but I know it is a problem in a number of languages that we have this dignity as we understand it in WIA versus this kind of dignified, that it's about comportment and manners and propriety, and we think about, bestowing honors on someone or things like that. We have to really clarify and talk to somebody who's saying, well, we need death with dignity. Well, what's an undignified death, right? What makes it undignified? And challenge them and ask them to articulate why they think that dignity goes away, and help them understand that there's a difference there. But what it really comes down to is these kind of major arguments. So I'm going to go through each of these as well. And I am trying to keep an eye on the time. So if I'm going crazy, Ella, jump in. But just to go through some of these and go through each argument. The two that really come out a lot are autonomy and pain and suffering. These are not the only arguments. You might also see some very utilitarian arguments about the costs of paying for people's care at the end of life, but that's not what is usually advanced, even though it can be kind of an undercurrent there. So let's talk about autonomy. And I put this claim there a lot because I want to actually unpack it later. But the main claim, right, mentally competent, right, so somebody who has the ability to think and reason relatively clearly, terminally ill adults should be able to choose to end their lives with assistance from doctors, right? That would be kind of the main claim there, right? And I want you to keep thinking as we talk through this about that mentally competent, terminally ill adults, right? So somebody who has the capacity to make decisions, somebody whose life is nearing its end, and who is an adult, right? And we'll talk about how those things aren't always present later. So the main argument, right? Everyone has a right to make his or her own decisions. That's not a problem. We agree. Good, an area of agreement. Okay. And then society should respect that right under certain circumstances, and under certain circumstances assist people in exercising that right. Okay, this could be fine. It's just going to depend on what the decision is. Then you might say, well, we don't criminalize people for committing suicide, right? In some cases they have unfortunately died. And in some cases they have survived and hopefully are getting treatment and help to avoid that. But we don't treat that person like a criminal. So if somebody has a really terrible experience where they're suffering, they're dependent, they're very ill, the argument would go, we shouldn't criminalize people helping them to end their lives as they wish. It wouldn't be a crime for them to do it. They have a really good reason. So why should we criminalize somebody who is acting out of compassion to help them? Okay, that would be the argument. I'm not saying that's what we think, but this is the basic kind of elements. So then we have to think about, okay, well, autonomy is something that is important, right? We do want to respect the free choices of people, but are there any limits, right? Well, the very obvious one is that you generally can't use your autonomy to harm other people. There is a saying that gets passed around American court and lawyer communities, something like, my right to swing my arms ends at your nose, right? That I can do what I want to a certain extent, but when it impacts somebody else, then it might be the subject of some rules or restrictions about that. So that's very clear. But in this case, right, with assisted suicide or euthanasia, the person wants to end their own life. So outside of this context, right? We value the person's life. We limit this because we as a society believe that they're a society. And so we always want to care for and affirm that person's value, even if that person can't see it, even if they themselves struggle to see it. And of course, there's other concerns there. We don't want unnecessary suffering. We have to take care of that person well, which can be an issue. But this fundamental reasons for prohibiting those actions are still valid in this case. The other question is assisted suicide really an autonomous act? Is this something that only the person does, right? Courts have recognized autonomy in some of these cases, like the Pretty versus UK, which is mentioned in the white paper, where they said, there is some interest there because this woman had motor neuron disease and was suffering a lot. It's hard. I don't want to pretend that these are not hard situations, but that basically the British government has an interest in protecting life, in protecting the vulnerable, and protecting the integrity of the medical profession. So we have to ask, is the person acting alone, right? If someone sadly ends their own life, we don't want it to happen, but we might not be able to prevent it, right? But in assisted suicide, it's not just one person acting, right? They're asking for assistance and they're asking for legal protection for that action, which is ending their life. So why should we accept suicide in some cases and then discourage it in others? That really gets into assessments of, what's the value of the person's life? Why do they have that value? And are we valuing some lives less based on certain circumstances, right? So if we're going to assist it in some cases and prevent it in others, now it's not so autonomous anymore. And we're getting into areas of different treatment on the basis of characteristics other than being a person. And then, of course, assisted suicide doesn't just require that person. It requires medical professionals to approve that person for assisted suicide. So they have a gatekeeper function. So what lives do doctors think are worth protecting or preserving? And what lives do they agree, oh, yeah, well, that's really a hard situation. We should allow you to take this medication. And then, of course, they're also providing the medication. But it's not just that, right? It's society's acceptance of that practice. So this is exactly where it comes into what suicides do we consider acceptable and not. And that really indicates what lives we think are valuable and are not. And so we really have to think hard and long before we determine that we can make that assessment, because it opens up the door to all sorts of assessments. Oh, this group, well, they're not really that valuable, right? We've learned the hard way in the last century that that's a terrible way to do things, and all it leads to is destruction and pain and grief. So it's really important that we understand that that's the risk here. Will that make it harder for society to oppose other suicides is an open question. I think it's going to be really hard to say, well, you should not kill your life, but if you were really sick, it would be fine. I think it could really undermine other suicide prevention efforts. And I think it's really important that we value everyone. Okay. Take a look at some of the comments here as well. Okay, so the other thing is, even if we kind of posit, all right, it's autonomy, right? Is it really autonomy? Is there maybe an element of paternalism? Could there be some coercion? We do have reports of non-voluntary euthanasia. There's a number of cases, studies from Netherlands, Australia, Belgium. These are in the white paper showing that there are a significant number, not a majority, but like somewhere around 3% of cases where doctors administered death hastening medications without any request from anyone. So if it's about autonomy and the person actually isn't making the choice, well, what kind of autonomy is that? Okay. We also have a risk of coercion. Okay. We have a case that we outlined in the white paper about a woman named Kate Cheney. Kate was not as able to engage in activities that she liked, but she didn't seem to have a really strong commitment to ending her life. However, her daughter did. Her daughter thought it would be better. And so I think what they ended up doing in that case is the daughter sent her to a nursing home where she would get, instead of keeping her at home, where she didn't get as much personal care, where she was removed from her family, sent her there for a week, basically to encourage her to take the life-ending medications that they had gotten in the U.S. state of Oregon, I want to say. And so, is that nobody's forcing the pills down her throat, although we don't know because nobody was there. But is that really a free choice? A number of court decisions have noticed this. The Pretty versus UK, some of those issues come out where the courts have said, there's a lot of good reasons for not allowing this practice. So we're not going to create a right to it. Not every court at this point, because as I noted before, we do have some court decisions saying it's a matter of autonomy. But the European Court of Human Rights, the US Supreme Court have essentially said there's good reasons to ban this. And we're not going to find that there's a fundamental right to this when the interests in the other way are so strong. Okay, so you say, all right, maybe autonomy is questionable. Maybe there can be elements of paternalism or coercion. Maybe there's some problems of autonomy, but what are you going to do when somebody's really suffering? How are you going to answer the great pain that some people experience at the end of life? Okay, and so the claim there is going to be something like, if we care about people, we don't want them to suffer, right? We should allow mentally competent, terminally ill adults to end their suffering with medically assisted suicide or euthanasia if they're not able to physically administer the life-ending drugs. So this is the basic argument. I already kind of went through it. Serious illness leading up to death can be an experience of profound pain and suffering, okay? That is a reality that we, as an organization that opposes assisted suicide, we have to be really clear on that. And it's really important that we are never glib or dismissive, even accidentally, of the reality of that, okay? It's really important that we take it seriously. And because we take it seriously, we do care about empathy and compassion, okay? So then the next part of the argument says empathy and compassion lead us to want to ease suffering, and we should ease suffering. And I agree, we should try to ease suffering. But then it's the next step that really gets to the action being wrong, right? So in the first one, we think about action and intention. The intention is autonomy, to respect their free will, and we see that there's limitations to that which are a problem. Here, the intention is a good one. It's coming out of compassion. Right. So, but the action itself, right, remains wrong. If the suffering person wants to end his or her life to avoid unbearable suffering, we should help them to do so out of compassion. That would be the argument, not Waya's argument, but the argument here. So then we should actually ask people, ask, why do people want to hasten their death, right? And so we should be looking at, why does this person in any other situation, right? If somebody said, I want to end my life, we would say, why? And how can I help you not feel like that? Okay. So the first question is that person's pain appropriately managed? There are serious gaps around the world in terms of good pain management. Okay. It's a real problem. And so that's going to take a big commitment to address. Do they feel their pain is being taken seriously? One study from a very prestigious cancer hospital in New York City found that patients often expressed a desire for hastened death, which is how they're describing this, actually just to get doctors to take them seriously about their suffering. Okay, so they're saying, I just want to die. Could you just end it already? Because they felt like they weren't, their suffering was going unnoticed and untreated, and it was really problematic. Are they depressed? Actually, is a big one. So when somebody is actually, pain and depression go together. It's not surprising when you say it, but there's like a big relationship between them. Depression makes pain worse. Pain can make you feel depressed. So you might have to treat both of those aspects, right? In somebody who doesn't have a serious illness, if they express a desire to end their life, we assume that they have some sort of mental health problem, and we want to treat that. But somehow when it gets into the assisted suicide context, we just say, well, yeah, obviously they're depressed, their life's awful, let's help them end it, which is a terrible sort of response to that. The other thing is, what sort of suffering are we easing? Certainly pain control is a factor, but this is from the Oregon report from last year. Every year, so it was published this year, it's last year's numbers and statistics. Oregon is one of the jurisdictions with the most thorough reporting. Most reports are not that thorough. Belgium and Netherlands have a lot of things, but some of it doesn't actually give you this data. So why did people say that they wanted to, that was a primary concern for them at the end of life? 90% can't engage in activities that make life enjoyable. 86% losing autonomy, right? And 72% saying loss of dignity, which I think is really coming into dignified, right? Dignified living. It's really about dependence, right? And so there's an idea that dependence lessens your dignity. And then when it comes to, things that are actually pain-based, right? Inadequate pain control or concern about it, not necessarily happening, about a third of people, right? And other kind of losing control of bodily functions, 40%. And if you look across, they've got 2018, the previous years before then, and then all of it, those numbers are fairly consistent. They're not necessarily exactly the same, but they're pretty similar across the board. So what suffering are we easing? Certainly for pain control is an issue for some people, but for a lot of people, they don't want to be a burden. They don't want to be dependent. They want to be able to do things that they enjoy doing. Suicide doesn't help that. So, the question I really have is that compassion? If somebody is before us saying, I am suffering, end my life, I am suffering and I need it to stop. It doesn't require a lot of us as a society to tell them, okay, here's a pill, go. It doesn't require fixing medical systems that don't take care of their needs. It doesn't require addressing the existential suffering and grief and depression that they may have. It doesn't require us to give really of ourselves, right? Compassion comes from the Latin word meaning to suffer with. We're not suffering with these people when we hand them the drugs and say, we'll bury you later, okay? It's really a cheap compassion, okay? The other question I want you to think about is, does this compassion admit any natural or logical limits? Okay, if the act of compassion requires us to help people end their suffering through ending their lives in some circumstances, why does it need to be at their request? Why should it be only children? Only adults and not children? Why should it be only physical suffering and not mental suffering? If we're really acting if that's really what compassion means, that we simply end suffering, then there's very few limits that will admit. There's very few limits to this process, okay? So that's a real big one. And I think that's exactly where courts have kind of come down, that they've recognized that that's an issue there. So then we have to think about, what is allowed in the name of compassion, right? I keep coming back to this. I keep coming back to this phrase, mentally competent, terminally ill adults, because I spent a disastrous 2.5 hours of my life watching a debate on this topic, which went nowhere. And the euthanasia advocate kept saying he wouldn't talk about any other possibilities. Anytime somebody said, but what about if it's this? What about that? And all he would say is, no, I'm talking about for mentally competent, terminally ill adults. But that's not what has ended up happening, right? So we have assisted suicide and euthanasia for reasons of unbearable psychological or mental suffering. That is allowed in, I think, Belgium and the Netherlands. I wouldn't be surprised if it ends up allowed in Canada. They're on that way. They're on that path. What if it's not imminent? We say terminally ill. There's no time requirement in the Netherlands. It just has to be likely. Also, doctors are not great at estimating life expectancy. So you can have somebody you think is going to die within 6 months. They usually also give an extra 12 months if it's motor neuron disease or some sort of neurodegenerative disorder. But actually, doctors are pretty bad about estimating life expectancies. And in Oregon's report on last year's data, Oregon is supposed to be 6 months. And yet they had one outlier person who who made their first request more than 1,500 days previously. That's a lot more than 6 months. I think it's 8 years. So you can see it's not actually is it imminent? We don't really know. And then, of course, assisted suicide for children, right? Why should it be adults? Why should children suffer, right? And so it just doesn't admit these natural limits. We have assisted suicide or euthanasia for children in Netherlands, Belgium, and Colombia. Canada Canada actually required an examination of this. I read the report. Yeah, I think they're going to legalize it soon. They tried to kind of reflect everyone's perspective, but there's a general sense that this is the right way to address suffering. Okay. So now we've talked a lot about the risks because I take a very integrated approach, but we do have specific risks, and these are the ones that I'm talking about today. Coercion, we've touched on that. Ableism, I did see a comment about that. So yeah, we are going to talk about that. There's a lot of ableism that is part of this. And changes to the role of the doctor. Okay, so coercion, right? Maybe I should have animated this one. Basically, you have a problem, right, where physicians, first of all, physicians are determining which lives are worth living and which aren't. That can actually exert pressure, okay? It's not, I'm not ascribing an intention to doctors on that one, but it has been shown to exert pressure on vulnerable groups. Let's say a doctor is discussing all of your options and you're sick and ill and, not feeling well. And those are all synonyms, forgive me. But basically, you're really sick and you might be depressed from that, might have all sorts of complicated feelings that you're working through. And a doctor says, well, you could do this, or you could do that, or you could end your life, right? That really can kind of exert expectations, right? Exert some pressure on people. Well, the doctor thinks it's probably better to end my life, even if the doctor didn't actually say that. There is some countries have rules where the doctor isn't supposed to bring that up. But that's going to be very hard to actually monitor, okay? And there could, of course, also be family expectations that play a role, right? There's a lot of evidence that a significant number of euthanasias in Netherlands come out at family requests rather than the requests of the person, okay? There's also can be pressure on physicians, okay? So one of the things that we discuss in the white paper is the case of a woman named Helen. Helen's family doctor didn't think that she really would benefit from assisted suicide. She didn't think it was appropriate for her. And so the family contacted an assisted suicide advocacy organization who connected them with a doctor who then, didn't call the regular doctor and kind of regretted it later, thought maybe this wasn't the right call. But because the family had made this effort, because they contacted him, because he was affiliated with this organization, kind of felt like he had to approve her for assisted suicide, right? And the other thing is, what about costs of care versus the costs of assisted suicide? We have examples, particularly in the US, where we have a very challenging healthcare system when it comes to meeting people's needs, where we have had people whose insurance will cover the ending their life, but not preserving their life. Okay. And there's also some report from Canada on that as well. Okay, a lot of these do overlap between the coercion and the risk to people with disabilities, etc., because there can be some vulnerability. Okay, then when it comes to risks to people with disabilities, again, which lives should be preserved and which are sufficiently bad to justify assisted suicide, right? That Michael Hinckley case that I mentioned at the start, that's a quality of life case where the doctor basically said, why should I, in this time of medical scarcity, why should I work to save the life of a man who is quadriplegic and has some brain damage, whose quality of life he assesses as bad, versus somebody who would have a great quality of life if they recover from COVID, right? So physician assessments of this quality of life have a real impact on patient care, and they tend to rate quality of life lower for people with disabilities than those people with disabilities actually rate their own lives. People with disabilities are perfectly capable of having great lives, you know, and it's not just about their disability. I don't want to speak for people with disabilities. I try to echo from those groups. I think they've made the arguments really well, and I strongly recommend checking out some of those sites like Not Dead Yet. But many people with disabilities face serious barriers to care and to participation in society, right? If everything's flat, you can get a wheelchair anywhere. We put the high rise in, and now we have to make sure it's everyone can benefit from it. Everybody can access it. Well, medical care, there can be a lot of costs. There can be challenges there. You know, and are we making sure that bias isn't creeping into medical care? You know, a lot of people with disabilities have stories of being mistreated in medical situations. Okay, so will the costs of their care kind of create, you know, make them look like a burden on society, on their families, on the healthcare system? Is that going to create kind of a duty to die? Will they feel like they have no other options? And so I think I also want to highlight this. This is a great cartoon from Amy Hasbrook of Not Dead Yet, Toujours Vivant Canada. So Canadian groups often have English and French names. That she drew this, and you can see, you know, a wheelchair user. Assisted suicide has a ramp, right? She can access that. But suicide prevention, there's barriers, right? And there's a lot of things about this that really come down to these real experiences. We have some pretty troubling cases related to this. I think the most egregious one is, I think his name was Sean Taggart in Canada. He was a wheelchair user. He couldn't move very much, and he needed a lot of care. He needed pretty much 24-hour care around the clock. And he was not given that care by state health authorities. They gave him 18 hours of care. Then they upped it to 20 hours of care, but he really needed around-the-clock assistance. And so his options were to have not enough care, or to go live in like a nursing home or a healthcare facility where it would have been harder for him to care for his son. He had a son who he had custody of at least part of the time. I don't believe he was currently married. And he wanted to be able to have his son at home with him. And he tried to get the care from the authorities to make sure that he could do that. And he didn't get it. And so he ended up choosing to end his life under the Canadian Death with Dignity Act, or whatever their act is called, rather than have this what he considered an untenable situation of being kind of more removed from his son or not getting adequate care at home. Right? There's been a lot of cases in which people with disabilities have been treated unfairly by medicine, by medical establishments, and by the state. And so, you know, they see themselves very much as I don't know if you have this expression in Poland. In English, we have this expression, the canary in the coal mine, that down in the coal mines, they would bring a bird. And if the bird was struggling or died from not being able to breathe, then it was a signal to all the miners to get out, right? If the bird's struggling, the humans are going to struggle soon. So the canary in the coal mine refers to somebody who is, you know, when it happens to them, it's a sign that it's going to get worse for other people. And disability rights groups generally oppose assisted suicide very strongly because they see it basically as another way that they are not going to get the equal access to care so that they can live out their lives like anybody else that they should have. And there is a lot of ableism embedded in medicine and in society. I think it is really a truly and sadly still an acceptable prejudice in many ways. I have heard comments. I heard even New York City seems so progressive and enlightened. A woman I was waiting at the bus stop and the bus was taking longer than expected. And we were speculating on why as this woman I didn't know. And I thought, oh, maybe they needed to use the ramp, you know, for somebody in a wheelchair to get onto the bus. And she just casually said, those people really need their own services. And I just said, well, I prefer everything to be integrated. I know, didn't make a big fight out of it, but just those people need their own things. Keep them out of my way. Right? And realistically, right, we're all dependent in different ways at different parts of our lives. People with disabilities might have additional needs, but we're all going to be in that situation at some point, right? And it's important that we take care of everybody throughout their lives in all of those ways. Okay. Lastly, it's really going to change the role of the doctor, right? So what is the doctor's role? Well, primarily doctors are there to heal and to ease suffering, okay? As we've talked about, ending someone's life isn't actually easing their suffering, it's just ending their life, okay? And also ending someone's life is not healing them. Now, you can't heal every condition, right? We can do our best to try and help make sure somebody can live their best life. Some things certainly can be healed, okay? But, you know, you can always address the suffering and be with that person in that way. Can a doctor participate in assisted suicide and advocate for patients to receive care that may be scarce or hard to get? A lot of medical societies are very concerned about promoting assisted suicide or euthanasia. The American Geriatric Society said most elderly persons experience serious and progressive illness for extended periods before death and need significant social, financial, and medical supports. These resources too often are not available, are of inadequate quality, are not covered by insurance, and are not provided by public entitlement programs. By collaborating and causing early deaths, when continuing to live has been made so difficult, geriatricians would become complicit in a social policy which effectively conserves community resources by eliminating those who need services. And I couldn't put it better than that, so I let them speak for themselves. But geriatricians, gerontologists care for the elderly. And so they say we would be complicit in basically ending lives to save money if we did that, right? Can you trust a doctor? This is another one. Can you trust a doctor who's allowed to kill you to work to preserve your life? I'm sorry if the grammar is a little strange on that now that I see it. Would you trust a doctor to preserve your life if they're also allowed to kill you or end your life legally? Not necessarily without your request, but it might just be in the back of people's minds going, okay, you know, and I think that's why actually support for assisted suicide is very low among groups that have been marginalized historically. So in the US, that includes African Americans, very low support there. It's very low support among Indigenous peoples. Tasmania, I think it was, in Australia briefly allowed assisted suicide back in the 90s. And they changed the rule actually because what they found was Indigenous people just stopped going to doctors because they didn't trust it anymore, because in the past, those communities were mistreated by doctors and medical professionals. And so they saw that as just another way that they would be mistreated, okay? You know, will a doctor feel obligated to assist someone who wants to end his or her life and not necessarily give them a long, give them the full treatment or the care that they deserve? The case of Helen that I mentioned earlier is an example of that. I can also say that the Oregon numbers show kind of averages of the doctor-patient relationship. You would kind of expect somebody at the end of their life probably has had the same doctor for several years, but the average doctor-patient relationship time for people getting assisted suicide is like 14 weeks. So it's not even 4 months. And there is definitely an element of doctor shopping, just like the case of Helen, where then that doctor's thinking, well, they came to me for this, I better give them this, right? And then, of course, what if a doctor doesn't want to participate in that? Are they going to have a right not to participate? Or do they have conscience rights? Or will they have to refer? What will they have to do in that? And what level of participation are they expected to have? If that's considered ethical, will your personal ethical objections be respected or not? And that's an open question. And the only legislation that addresses that in the most detail and doesn't The one that addresses that most, I would say, is the Victorian law, which actually doesn't seem to require a referral. The other ones, I think, say you don't have to do it, but it's a question of, do you have to refer for that? And what if you think there's really something else behind it? Can you communicate that to the other doctor? I don't know. Okay, so what are we actually going to do? Okay, I said we can't just be against the bad things. We have to be for the good things. So how do we ensure respect for dignity at the end of life? Right? Everybody has that dignity. Therefore, we care about them, and we need to show that in what we do. So there's three big things that we talk about in our white paper, and that I'm going to go through. Not too much time on them, but I think they're really important. First, a lot of it, look, doctors get into medicine because they want to help people, they care about people. I don't want to be anti-doctor here. We might have med students or doctors in the crowd. I know that many people are getting into this for wonderful reasons. And so I think that it's great, but sometimes they need more support, right? So that comes into kind of improving that communication, particularly about end-of-life issues. We also have a great need for palliative care, and then palliative care and psychosocial support really go well together. And I think probably there are some palliative care programs that include psychosocial support, but because there are some unmet needs there, we think it's really important to pull that out on its own. So doctor-patient relationships. It's really hard to talk about end-of-life care. It's really hard. I don't envy doctors. I'm a lawyer, and I don't do wills or trusts, so I don't have to talk about that with anyone. But it's tough. And doctors and nurses report that they find it really hard to start those conversations. So they probably need some training or support to do that. And it's especially hard when it might be getting to a place where there really isn't a cure and there's very little chance of that person fully healing, okay? And so, but what happens when they don't have those conversations isn't nothing gets done. It actually can lead to more interventions because the patient doesn't really understand their situation. And so actually a lot of people don't want very intense, prolonging their life for any means, okay? It often, a lot of people would rather have kind of take the time that they have and do more with it and just kind of live as well as they can for as long as they can. And so when when doctors are able to have those conversations with their patients get the kind of care that they say they want. And that could be more intervention or less intervention. It could be focused more on pain management, or it could be focused more on kind of taking care of certain, being able to do certain activities. But that really can impact other interventions. So Wyatt isn't taking a position, people should, do everything to prolong life, or people should just accept that they're dying. We're not taking a position on that. But people really need to be addressing, we need to be addressing what are the patient's actual desires and needs. Are we managing their pain appropriately? And we have a great story in the white paper from an article I spotted a few years ago from a doctor who had a patient come in, and because he had a different approach, he was more kind of palliative focused. He said to the patient, he had an option for something more high intervention, which would have required him to be in the hospital. Patient wasn't going to live super long. And he said, well, what do you want out of your care? And the patient basically said he wanted to stay at home and he wanted to be able to walk without falling over. The more intensive medications would have preserved his life longer, but not forever, of course. And also, it probably would have put him off balance. So the doctor instead adjusted the medication and, kind of kept in touch, and he had he had support at home and things like that. And the end result actually was that when the man's wife herself was facing later a terminal diagnosis, she went back to that same doctor because that care really, really made an impression on her, that it allowed her husband to live as he wished as long as he could, and pass into out of this world with ease. Another thing is, of course, palliative care. Now, there's a lot more to palliative care than this. I've kind of pulled out some of the highlights. Palliative care is not about hastening death. It's not about delaying death. the idea is to alleviate that pain and suffering. So this is really making sure that we are meeting those healthcare needs, particularly in pain relief, but not only. It really is a very holistic approach. It offers a lot of support to the patient and their family. It treats the process like it's normal, right? Which it is. We are all on this journey, and it's going to be however long it is, and then it's going to be done, right? It's a normal part of our lives, is the end of it. The other thing that I do just want to highlight, it's a really wonderful approach. And honestly, if you talk to people who provide palliative care, they're really wonderful people. I've heard some talks, and they're just so full of care, and they really accompany their patients. It's really, really beautiful. But they get called in at the end a lot. Oh, well, actually we had this, the widow of a former president in the US, the word went out, she stopped treatment and is now receiving palliative care. Well, palliative care doctors and nurses will tell you, bring us in earlier, right? We're not just here for the last couple days. We will be there for a longer time if you let us come in and ease that pain. So sometimes the mistake happens where it's viewed as a last resort. And so it doesn't, and so when everything else fails, then we give you the palliative care, when it really should be part of the care much earlier. And then as other things don't work anymore, it's constant, it's consistent. And also, just as an anecdote, I noticed when I was researching Luxembourg recently, Luxembourg passed a bill that gave people a right to palliative care, and along with the assisted suicide bill. And so one of the people involved in the assisted suicide part of things complained that they weren't getting a lot of funding and that so much is being spent on palliative care. So it's kind of interesting. They're a very small country, so their small numbers don't necessarily mean that much, but they are, their per capita rate does seem to be lower on this. And then lastly, psychosocial care. This is really about psychological or psychiatric support to address spiritual well-being. When I say spiritual, this is in the psychiatric or psychological sense. It can include religion, but it's actually more generally about having a sense of meaning, a sense of purpose, addressing, some of those mental health issues as well. We had a great speaker at our International Solidarity Forum a couple years ago, who works at a premier cancer hospital and is a psychiatrist there. And he said about half of the patients just have depression. And we know actually how to treat depression, so we can address those needs. Interestingly though, because somebody is in a lot of pain and they're sick, it can be hard to identify those symptoms. I found fascinatingly, there's a study that shows basically it's as reliable to just say to a patient, are you depressed? And it's a pretty good indicator, actually, if they are actually depressed. But it's not something every doctor or nurse is kind of trained to do. So making sure that we train doctors and nurses to identify that and address it. And that is associated with a desire for hastened death. So if we resolve that, we can maybe resolve that. The other thing is that doctor told us he had designed things based off of logotherapy from Viktor Frankl, for those of you who've read your CTP or have otherwise read his work, where he found that a significant portion of the rest of people in his wards who were suffering with this had lost a sense of meaning and purpose. And so in being able to address, he actually designed some interventions to help them rediscover a sense of meaning and purpose, and that had had a big effect. So those are kind of our three big interventions. So that is what I have from my slideshow. And I guess we've got some time for questions now. And thanks so much for listening. Hopefully you didn't get tired of my voice during this.
Thank you, Nadja, so much for your very insightful talk. I know that this topic of euthanasia and assisted suicide is sometimes a very controversial one. So it's really good to know all the facts and all the arguments. Thank you so much for sharing them with us today. And now we move to our Q&A session. So let me call on Isa Villas, our WIA certified member, to join me and facilitate this segment. Hello, Isa. So we've been getting some questions in the comments. We have also some other questions. Could you start asking them to Nadja?
So I can't hear you, but I can see a question. I wonder if there's a mute setting somewhere.
Same, but maybe if you see them, you can just answer them as you see them.
Yeah, we'll figure it out in the back end. Okay, so would euthanasia and assisted suicide always be only at the patient's request? No. I think you're not going to find a huge number of people who will openly admit, medical professionals, that they do this without a patient request. But there are studies showing that doctors and sometimes nurses have engaged in assisted suicide, or basically euthanasia at that point, where it's not happening with the patient's with the patients expressing the desire to do that, or their wish. Another thing that has emerged recently, it was tolerated, but it actually had a court case recently, just last year in the Netherlands, is the use of advance directives. So generally speaking, if you would think that somebody who's mentally competent, they have to be able to make that decision at that time to end their life. But in the Netherlands, and I think in Belgium, you actually can make a request for assisted suicide or euthanasia by advance directive, where you say, okay, at this point, if I get to this level of dementia, or I don't remember my name anymore, or something like that, or I'm in a bad condition, please end my life. And so that's less, that's not exactly non-voluntary in the same way as no request, but the person isn't able to request it at that time. And the court case in the Netherlands, I was surprised the prosecutors brought it. I wasn't surprised when the doctor was found not to have done anything wrong, because they're very permissive. But essentially what happened was a woman had a previous request, and the doctor ended up carrying it out. And it seemed like, honestly, it was could have been a very terrifying situation for this woman who had dementia and therefore wasn't really able to understand what was going on, where they ended up holding her down to inject things like that. And of course, in the case of the Groningen protocol, you have infants who are not capable of consenting or understanding, but whose parents have essentially decided that their life is, either they won't live long or their life is going to be terrible. And that's another kind of, there's a lot of ableism in that. So I would say probably most cases it's at the person's request, but there are definitely a significant number where there is no active request, or the person might have requested earlier, but is no longer capable of consenting.
Mm-hmm. Thank you, Nadja. The next question can come. Isaac, can you hear us? Okay, this is the question from our comment section.
Mm-hmm.
This is a question from Fadili, and it is, could it be said that arguments for assisted suicide or euthanasia are fundamentally ableist? For example, they are based on the idea that a life of disability or morbidity isn't worth living.
Yes, a lot of them are. So if you're not familiar with the term ableism, I had it at one draft in the white paper, and then I changed it to disability discrimination, because I know not everybody knows that term. But ableism would be, able versus disable, where it's discrimination against people with disabilities. I think a lot of this relies on discriminatory attitudes about disability and underlying beliefs that it would be terrible to live that way. But most of us, especially if you live long enough, right, which hopefully we all will, most of us are going to have some form of disability. Actually, some of us have it now, right? It's just like, what has society done that makes it work? If I lived 1,000 years ago, I wouldn't have a prescription like this, right? This is a disability. So even if I were one of the few lay women who could read, okay, I wouldn't be able to do it necessarily, because honestly, I don't have great eyesight. This is just a very common disability that we've adapted for. There are less common ones, or things that require more extensive adaptations, but we're just used to this one. But I think a lot of people, it really comes down to fears of dependence. There's a real connection between autonomy and kind of negative attitudes about disability. And there's, I mean, people with disabilities are some great self-advocates. I don't want to speak just for them. I encourage you to go look at those organizations and what they say about things. But just to kind of reiterate what I have spoken with and learned from people in those communities, yeah, there's a huge strain of ableism there, where it really comes down to people, the worried well, right? They anticipate how awful their life would be if they had to live like those people who need assistance in their daily lives, right? There's a lot of that, absolutely.
Okay, so the second question, would euthanasia and assisted suicide always be only at a patient's request?
I think we got that one, but the answer is no. It's not always at the patient's request. There are definitely cases where it isn't. I gave a fuller answer while you were kind of sorting out the tech stuff. Yeah, it'll be nice if the people can watch the replay on this.
Yeah. So the question from comment, as you can see, is what's the role of beneficence or non-maleficence in euthanasia?
Interesting. Okay, so I think beneficence, so doing something that's good, or kind of a beneficial, non-maleficence, not harming, right? I think when it comes to euthanasia and assisted suicide, it really has an issue with the do no harm idea, which is kind of the first rule from the Hippocratic Oath, first do no harm. So that would be non-maleficence. Ending someone's life or taking direct action to end their lives in any other circumstance, we don't have a question that that's wrong. We all know it's wrong. So I think the burden is on people promoting assisted suicide and euthanasia to prove why it shouldn't be wrong in this circumstance. In terms of beneficence, I think many of them think they are doing it from beneficence. And I think there are some genuine elements of compassion there, but it's a misdirected compassion. So remember, you can't just say, it's the compassionate thing to do. We have to evaluate the actual action itself in light of reason and what is good. And a person is fundamentally valuable, and so we should not end their lives, right? So I think that a lot of people would view, who are advocating for this, would view it as being beneficent, but I think that it is violating a principle of non-maleficence because it is in fact doing harm to someone by taking direct action to end their lives or assist them ending their lives. Okay. All right.
So the third question, isn't opposition to euthanasia and assisted suicide just an attempt to impose religious beliefs on others?
Yeah, I don't think so. I want to make sure I said yeah, but I actually think no. I think you'll probably could see this argument a lot, right? Don't impose your values on me. But these are not just religious values. There are wonderful opponents who are not to assisted suicide who are not religious. If you look back on this presentation, nothing I have said has religious content. So you can clearly make a reasoned case without that, which is what WIA does. We make our arguments based off of kind of universal principles and arguments that are accessible to everyone. We certainly are friendly towards anyone's religious beliefs, but we have people from all over the world. So there are different beliefs on all of these things. I think the fundamental thing that it comes down to is, do we think that every person has the same value as every other person or not? And you don't have to be religious to believe that. And I think also I would just point people towards other things that happen. So or other works. One of the sources that we used in the white paper was from an author named Kevin Ewell. He is, I believe, British, and he wrote a book titled something like The Secular Humanist Case Against Assisted Suicide. So his whole book was essentially marshalling arguments from a specifically non-religious perspective. And I thought he had some great insights, and actually I took a lot from him on the idea of compassion and the cheap compassion, and he is not a religious person. I think, if we're not prepared as humanity to affirm the fundamental value of every single human being, then we got a lot bigger problems than whether religions agree with that.
Okay.
So this is a question from comments, and it says, can I ask a question? If yes, the role of doctors can be concerned like an expert's opinion under the Evidence Act?
So I don't know where this Evidence Act is from. I think I'm seeing Aung San Suu Kyi in the person's profile picture, so maybe Myanmar, I don't know. Doctors certainly can give expert opinions in courts in many cases. I'm assuming that's pretty common around the world. But I think the question is, what is their actual expertise? So something I actually read an article yesterday about this topic, where the person pointed out that, of course, the doctors reviewing the euthanasia cases in the Netherlands, they have a small group of experts. It's not their full-time job. They can't possibly assess every single they don't all have all the specialties of the illnesses that are considered reasons why somebody is allowed to commit suicide. So they can have an expert opinion in some things, but it's not possible to be an expert in everything. So the fact that they might be able to give evidence in court on something in particular doesn't mean that they're going to be actually able to assess everything. And I mean, when I saw that new Oregon number of 1,500 days between the first request and actually taking the pill, and just a study showing that it's actually really hard to guess how much longer somebody's going to live. I don't blame doctors for getting that wrong, but in light of how easy it is to get wrong, and the fact that they're probably not getting feedback about their accuracy, and individual medical cases are so individual, they're so specific to the person, it's probably wrong to expect them to be an expert on something like that, which is actually pretty important in these assisted suicide assessments. Whether it's unbearable or never going to improve is pretty common across all of them, even if they don't have a specific 6 months time limit, for example. So I don't know if that exactly answers the question, but I'm a lawyer in the US. I don't know everything from Myanmar, but thank you so much for joining us from there. I think it's really just about what is the person actually qualified to get evidence on. If you have an oncologist, they specialize in cancer, they can give you a lot of evidence about cancer. They might not be as accurate as about life expectancy, and they certainly won't be accurate about childbirth.
Okay, so next questions. What are the effects of euthanasia and physician-assisted suicide on surviving family and friends?
Well, that's interesting, because I think that, we have a lot of family, particularly in Europe, it seems like family is a big push for assisted suicide. In a lot of these cases, a lot of the requests are coming from family, or family is influential on the requests. So I don't know how that's going to affect somebody to participate in something that is wrong. I would be curious to see if, for example, do they feel at ease with this? Because it's so socially accepted? Do they feel guilt over this because they participated in ending probably their parents' lives? But we do have cases where people were upset about their parents doing this. Actually, there is a case, it hasn't done very well. I think they're appealing again. There is a case with, I don't remember, I think it's a Belgian woman, where her son is suing because psychological distress, and was given assisted suicide on that basis. And he didn't even know basically until the end. And he felt that it was done wrongly and inappropriately, and he felt like the state helped kill his mother, pretty much, or helped her end her life when they should have been helping her to deal with her depression and her mental health issues. So certainly that can leave a lot of grief. I think it's hard to know the psychological effects on that. I am very concerned about the broader social effects of a society that is prepared to accept that some lives just aren't worth living. So it's all speculation, but there are certainly people who are upset about it. There's certainly people who probably accept it and are at peace with it. Sometimes you do see stories of how peaceful and nice it was that they went in that way, or a family surrounded this athlete who ended her life because she was, tired of being an athlete with a disability, sort of thing. But yeah, so I don't have like a more concrete answer on that.
Thank you so much for all the questions. It's great to hear from you, to see your suggestions and comments. Any final words to close the session, Nadja?
So one thing I usually tell when we're training interns, we do all these discussions on these white papers. All the white papers are on the website. Don't be intimidated that this one is the longest. And actually the last 44 pages are actually as of right now, or as of when it was written. There's a lot of push for this. So I would encourage you to really be aware of what's going on in your own country. It can, the advocates paint a very, very nice picture of, this person having this beautiful, peaceful death at their own will, and this kind of, but they skip over all of the really troubling implications. And I also really want you to think about that cheap compassion, okay? I always tell my interns, everybody ought to be loved into this world and they ought to be loved out of it. We kill the first one so well, okay? Hopefully people come into this world through and are loved and are entered in that way. But we can't control all of that. But we can control how we treat people at the end of life. We can accompany them, we can love them, we can care for them, we can be with them, we can meet their needs. But it's gonna take effort. And it's going to take consistent pressure and effort and work to make sure that that is what we're doing. That we are, putting the budget in our, national budgets or regional budgets for that. That we are promoting, this sort of holistic care. That we are, not just putting it onto doctors, but giving them the tools and giving them the support to help support their patients well. And so, think about the kind of world that we want to live in. Is it one where some lives just are so bad that we should help end them? Or is it one where everyone is cherished and loved throughout their life and accompanied at their death?
Thank you, Nadja, so much for being with us today. I hope that this session and our sessions were helpful for you. If you want to be the first to know about our upcoming events, I encourage you to follow us on World Youth Alliance Poland. You can see on the screen. And if you haven't already done it, follow us also on Twitter and Instagram at WIA Europe. You can apply to the Certified Training Program. CTP is the collection of texts that provide philosophical underpinnings of the mission of WIA. It presents a summary of philosophical, historical, and also modern-day texts that focus on the dignity of the person and human rights. This program is free and open for all members of World Youth Alliance. It is a prerequisite for many programs, for participation in many programs of WIA, such as internships or specialized conferences or advocacy work. So I really encourage you to check it out and check if that works for you. Lastly, if you are watching this, please don't forget to fill out the evaluation form and let us know if it was helpful for you. Again, thank you so much for joining us. Thank you, Nadja. Thank you all of you who are here. Thank you. And I hope to see you again soon. Bye. Bye-bye.
Bye.
Take care.